Hello, my name is Dr. Vanessa McGregor. I'm a consultant in communicable disease control, bit of a mouthful, with the UK Health Security Agency. And this afternoon, I'm here to give you a talk on bloodborne viruses. Um, I'm hoping to talk for 20 to 25 minutes so that we'll have some time for questions afterwards. But I am happy to be interrupted. If you have a burning question while I'm talking, you want some clarification, do please indicate, and somebody will bring a microphone round. Please wait until the microphone has come to you before you ask your question, because apparently it's all being recorded. Okay, thank you. Let's get a move on. So, bloodborne viruses, protecting staff and patients. So again, what are bloodborne viral infections? So these occur when certain pathogenic agents are transferred from the blood of one person to another. They could be bacteria, viruses, or parasites. However, bloodborne viruses are what we're going to focus on today. And the reason they're important is because they can persist in blood and body fluids of affected people, and they can be transmitted to others through various routes, often in an occupational setting. And occupational settings, particularly healthcare workers, are one of the highest risk occupations where you might be in danger of getting a bloodborne virus. So there are three main ones of public health importance that we talk about: hepatitis B virus, hepatitis C virus, and HIV, the human immunodeficiency virus. There are some other bloodborne viruses that we are keeping an eye on, that they might be becoming important, although the significance is not yet known. So hepatitis D virus actually is like a variant of hepatitis B. You have to have hepatitis B first before you get hepatitis D, but it can also be transmitted through the bloodborne virus route. Hepatitis E virus generally causes a gastrointestinal infection, and is fecal-orally transmitted. However, through bloodborne virus screening, we are detecting hepatitis E virus in the blood of people who are donating blood, and the importance is as of yet unknown. Most people who get hepatitis E as a disease tend to recover completely, so it may not be of significance, but just keeping an eye on it. And then human T-cell lymphotrophic virus types 1 and 2, viruses a bit similar to HIV. Small number of people are infected, but it can also be transmitted through the bloodborne virus route. Again, significance as of yet unknown. So how are bloodborne viruses transmitted? Well, on a global scale, the most common routes are through sexual intercourse, through sharing injecting equipment, and drug paraphernalia, skin puncture with sharp objects contaminated by blood of an infected person. So for example, we'll be talking about this. This can happen in healthcare settings, but also in community settings, for example, through contaminated tattooing equipment, as an example. Vertical transmission from mother to infants before or during birth by breastfeeding. Worldwide, this is probably the commonest route in countries where, for example, hepatitis B is very endemic. Most people actually get it during the birth process through childhood. And then transfusion of infected blood or blood products where screening for BBVs has not been undertaken. Now, 40 years ago, this was a common route. In countries like the UK, it's an extremely uncommon route now because all blood is screened. But in some countries where screening may not always happen, it can still be a risk through that route. Less common routes are through open wound contamination, skin lesions being contaminated with blood, splashes to eyes, nose, or mouth, or human bites. Human bites can have been known to lead to bloodborne virus transmission, but the bite has to break the skin and there has to be blood involved for that to happen. So I'm going to focus particularly now on bloodborne virus exposure in healthcare settings and the routes that this can happen, particularly with relation to healthcare workers and patients. However, while this same routes can also occur in community settings, so to a lesser extent in some community settings such as care settings, but they are slightly lower risk than healthcare settings where patient care is happening. So the main routes that can happen are nosocomial, which is when a patient is infected with a bloodborne virus and that infection is transmitted to a healthcare worker. Then we have iatrogenic, and this is where the healthcare worker is infected with a bloodborne virus and may transfer that infection to a patient. And then the healthcare-associated infection is where a patient with a bloodborne virus may transmit that infection to another patient, usually not directly, but through other routes. And it might be healthcare workers might be involved in that route, either through what they're doing or not doing, or through equipment that has been contaminated and then transmit to another patient. So I'll go through these three routes so that we can look at some of the ways by which these transmissions can occur. Looking at nosocomial exposure, so this is from a patient to a healthcare worker. The two main routes for this kind of exposure are through what we call percutaneous exposure. So this is when needle stick injuries, as we call them, we all love them, needle stick injuries, NSIs. So these are when healthcare workers are injured as a result of a needle stick or cut with a sharp instrument that has been contaminated with blood or body fluids. This route also might include human bites and scratches, particularly where blood is involved. And then the mucocutaneous exposure is contamination of non-intact skin, conjunctivae, the conjunctivae or mucous membranes to blood or other bodily fluids. So this is, splashes, for example, or, if someone has eczema or broken skin, cuts and abrasions, and they are exposed to contaminated blood. So to further talk about these nosocomial exposure routes, I'll give you some data. So UKHSA, where I work, for many years we had a surveillance system where we looked at significant occupational exposures to bloodborne viruses. So all healthcare organizations were encouraged to report if they'd had needle stick injuries, and they had to fill in a questionnaire telling all about the injury, what happened, and we also did follow-up of those exposed healthcare workers. So this, at the moment, it's been suspended, the surveillance scheme, but it did run for many years, and this was the last report that was produced. So it is 10 years old, but the data, I think, is still quite useful to show in real life what actually happens to these exposures. So this is looking at a 10-year period from 2004 to 2013. And for those injuries that were reported, 54% of those patients were infected with hepatitis C virus, 30% with HIV, 9% with hepatitis B, and then a small proportion, 70%, had co-infections. So they had more than one bloodborne virus. And again, from that the 7%, the most common combination was HIV and hepatitis C, followed by hepatitis C and hepatitis B co-infection, and then much smaller numbers, only 19% had HIV and hepatitis B, and a small proportion had all three bloodborne viruses. So looking at what kind of exposure type, so 71% were percutaneous injuries. So this is typically your needle stick or sharp injuries. And just about just under a third were mucocutaneous exposures. And for the sharps injuries, most of them, 65%, were from hollow bore needles. So that's your needles you use typically to collect blood or to give injections. A smaller percent, 21%, solid needles, and then other sharps, 14%. And then looking at the kind of exposure by the healthcare worker, most healthcare workers had a majority were percutaneous injuries, apart from in the dental setting, where they tended to have more injuries with solid needles, for example, or other sharps. Anybody who's been to a dentist, there's lots of sharp things in dental surgeries, apart from when they give you the anesthetic. But most healthcare workers, whether they were doctors or nursing assistants, generally tended to be more likely to have percutaneous injuries. Things like bites and scratches, for example, were more commonly seen in some of ancillary staff. So this might be porters or security people who have to restrain patients, as opposed to the percutaneous route. And then we also look at when these injuries happened. When do these needle sticks injuries happen or exposures happen? Most of them happen during the procedure that's being carried out. And then smaller proportions happen either after the procedure but before disposal of the needles. So these are when, people are, might be doing things like recapping needles. Hopefully nobody does that anymore. But those sorts of things before they're disposed. And then a smaller proportion again during or after disposal of the sharp. And again, just looking at by healthcare group, looking at when things happen again, most happens during the procedures. It does vary according to the different groups. With dentists, again, they seem to be more after and before disposal. And then just the last couple of slides to show on this report. So this is trying to make an assessment of the proportion of, what's the most likely bloodborne virus you might get after an exposure. And typically, if you look at most published data, we say hepatitis B is the most common bloodborne virus that you can get. It's 1 in 3. That's because hepatitis B is very easily transmissible. It can survive for long outside of the body, up to 2 weeks, compared to some of the other viruses. And then after hepatitis B, you get hepatitis C, which is 1 in 30, and then HIV, which is the least transmissible because it's the least likely to survive outside the body, 1 in 300. Now, looking at that eye of the needle report, looking at seroconversion following a needle stick injury, for those 10 years, we only found people who seroconverted for hepatitis C. We didn't find anybody who got hepatitis B or HIV following an exposure. But again, that's just in that cohort. And it also represents, because in the UK, hepatitis C infection is actually more prevalent in the general population than hepatitis B. So it's hepatitis C and then HIV and then hepatitis B. Whereas globally, it's the other way around. Hepatitis B is the most common bloodborne virus, the most prevalent of the bloodborne viruses. So but even looking at the rate of seroconversion for hepatitis C, it appears to be much lower than the 1 in 30. But again, this is a small data, and not everybody got followed up. We didn't get all the results, so there might be a degree of underreporting there, just to know. And then also looking at hepatitis B immunization status. Hepatitis B is a vaccine preventable disease. So it is entirely preventable by vaccination. And looking at the status of healthcare workers, their vaccination status before they were exposed, and reassuringly, most of the healthcare workers were people who'd been vaccinated and were known to have responded to hepatitis B vaccination. Only a very small proportion were non-responders, and again, an even smaller proportion were people who had natural immunity because they had previously been infected and recovered from their infection. And then just looking at, I mentioned that there was some people who actually seroconverted. So at the time of the injury, they were tested, and then they were retested 3 to 6 months later, and they had now become positive for hepatitis C. So in that 10-year period, there were 13 of these healthcare workers who seroconverted, 9 in England and Wales and 4 in Scotland. And the ones in England and Wales, which are the ones we follow up in UKHSA, we were able to establish of those 9, 8 were put on treatment for hepatitis C, 1 was lost to follow-up. And of the 8 who were treated, 7 thankfully cleared the virus and were cured. And there was 1, unfortunately, we never did find out what happened to that person. And then looking at HIV, again, HIV exposures, post-exposure prophylaxis is recommended based on a risk assessment. But generally, it's only recommended when you've had exposure to a HIV-infected person or a person of unknown viral load. So for those health exposures, 77% of healthcare workers were put on post-exposure prophylaxis, 21% declined or were not recommended to have PEP, and a small number where we had no reports. And of those who were put on PEP, about half of them started PEP within or less than 72 hours, which is what's recommended. A smaller proportion started PEP after 72 hours, but for about half of them, we didn't have any data on the timing of the post-exposure prophylaxis. But we do know that of that whole cohort, about 27% later discontinued PEP following testing or because they were not deemed to be no longer at risk. So that was just the outcomes of that Eye of the Needle report, which gives us an idea of particularly these nosocomial exposures, how healthcare workers can be exposed to patients and potentially get bloodborne viruses. So looking again at the other type, healthcare worker to patient. So these are when healthcare workers are infected with the bloodborne virus and might transmit to patient. So when you're looking at these potential exposures, the concept of exposure-prone procedures is what we use, is the key concept. So these are procedures that potentially could lead to a patient getting a bloodborne virus from an infected healthcare worker. Now, provided that healthcare workers are following their appropriate standard infection prevention and control procedures, most clinical procedures, including invasive ones, pose no risk of transmission to a patient from a healthcare worker who may be living with a bloodborne virus and can be safely performed. So just because a healthcare worker has a bloodborne virus doesn't mean they can't work. It just means they have to adhere to all the infection control measures. But there are certain procedures which we know that are higher risk than others, and these are called exposure-prone procedures. And this is where injury to a healthcare worker could result in the healthcare worker's blood contaminating the patient's open tissues, a procedure we call bleed back. And this is particularly, these procedures are where a healthcare worker's hands may not be visible at all times, and they might be in a patient's cavities. And these are places where sharp instruments, needle tips, or sharp tissues can then injure the healthcare worker, leading to bleeding into the patient's cavity, and where the healthcare worker may not be aware that that's happened. So exposure-prone procedures are divided into three categories. I'm not going to go through all of them, just to show you that there's three main categories. Most healthcare procedures are in the non-EPP category, so they're not exposure-prone, and the vast majority of procedures carried out in healthcare settings fall into that sort of group. And then you have category 1 EPPs going up to category 3, which are the most significant. Now, the reasons for these categorizations are important if, for example, there is a consideration or a suspicion that a patient may have been infected by a healthcare worker. And depending on that, if you have that suspicion and you need to look back onto what procedures happened to that patient, then the categories become important. Generally, if a patient has had category 3 exposure-prone procedures happen, then those ones might need to what we call a patient notification exercise, or look back as it's called, where you might then need to look at all the patients who might have been exposed to that healthcare worker and undertake testing to see whether they've been infected. Just to mention that there are also exposure-prone environments when we talk about. So these are not necessarily procedures, but these are environments where there may be, again, a significant risk of injury to the healthcare worker based on the kind of work they're doing. And then that can lead to transmission. So this particularly relates to ambulance or other emergency services staff who might be attending things like road traffic collisions, domestic violence incidents, or even worse, kind of terrorist explosion type instruments where there's a lot of, there might be a lot of blood and tissue around, and where there are sharp instruments where bleeding can happen. So it's also important to note if someone is working in an exposure-prone environment. So those are, as I said, those are examples of things that can happen where an infected healthcare worker may affect a patient. So then going on to healthcare-associated exposures, where patient-to-patient exposures might occur. So there's different factors that might lead to some of these transmissions occurring. And again, if everyone's doing the right thing, following our standard procedures, patient-to-patient transmission should never happen in a healthcare setting. This usually happens when something goes wrong and something is not being done right. So examples of things that might happen, so failure of decontamination of instruments, particularly endoscopes, if there's some sort of decontamination failure, or if they're not sterilized properly, that can lead to potential infection from the instruments. And then infected patients who are receiving things like dialysis or renal replacement therapies, again, there might be potential for those patients to transmit to another patient who are using a shared machine. So particularly in dialysis settings, which are quite high-risk settings, there's a recommendation that all patients who are going to undergo dialysis should be vaccinated against hepatitis B to try and prevent transmission. Inappropriate reuse of instruments, so for example, reusing single-use instruments, that can be a route if they're not, again, reused or they're not decontaminated properly. And then poor injection safety. I would hope none of these happen in our NHS today, but this is reusing needles or syringes and other sharps such as lancets, vacutainer barrels, inappropriate handling of multi-dose medicines. So, for example, using the same, needle and syringe for a multi-dose vial. Much as we say these things, in my job that I do, occasionally some of these things are reported to me. Increasingly, I have to say less and less, which is good. But we have investigated some of these kind of incidents before, or use of non-aseptic technique. And then lapses in IPC, so example, reusing or not changing gloves between patients. I was involved in a look back that involved a dental practice dentist who had been working for 30 years and had been videoed by a whistleblower and was shown that during patients they were using the same gloves, or even worse, taking off their gloves, holding them in their hand, going onto the phone, having a chat, writing the patient notes, and then putting the same gloves back on, and then treating the next patient. So that led to, and it treated at least over 22,000 patients. So that led to a huge patient recall. So again, as I said, it's unusual, but these things sometimes happen. And then use of unscreened or unregulated blood products or tissues. Again, this shouldn't really happen in the UK, but you'll be amazed what people advertise over the internet. You know, you can get stem cell therapy over the internet, you know. So all these kind of unregulated issues, you know, can happen. So anyway, as you can see, there's a theme running here in that, yes, these things can happen, but ultimately they're all preventable. And the prevention strategies are the same thing, you know, it's your standard kind of IPC things, you know, but with a few, you know, with a few things that might be added. So it's important, PPE, very important. These are all bread and butter to you IPC staff, so I'm not going to, you know, bother to go it through with you, but just to see. But yeah, it's, you know, is again having the right equipment and safe systems in work, risk assessments to be done to ensure it's safe for everybody, making sure practitioners are trained, they have information, and then where we have preventive measures like immunization, for example, that's offered, where there is treatment for, and while hepatitis B is, as I said, preventable by immunization, we don't have vaccines for HIV and hepatitis C, but hepatitis C is treatable and curable. So anybody who's got it should be offered treatment, and HIV can be treated, or viral load can be suppressed to make people safe. And then it's important for, you know, employers to make sure that they have procedures in place for reporting needle stick injuries and for investigating exposures and ensuring both healthcare workers and patients have access to the right treatment and follow-up. And if healthcare workers are living with blood-borne viruses, again, ensuring that the health employer is putting in place the necessary testing to ensure that they can do their work safely, if need be, or if they need to be stopped from working, from performing exposure-prone procedures, not stopped from working, that all those are in place. And just to mention a bit, for those of you who may not aware that there is a body called UCAP, which is the United Kingdom United Kingdom Advisory Panel for Healthcare Workers Living with Blood-borne Viruses. And they are there to advise for things to be put in place or how these healthcare workers should be monitored. And they currently also have a register where healthcare workers living with blood-borne viruses can be registered and ensure that they're receiving the right follow-up and testing to enable them to continue to work and to work safely. So again, a little bit just mentioned about safe disposal of sharps, very important in healthcare settings, particularly as most of the exposures to healthcare workers occur because of sharp injuries. And the WHO made some guidelines in 2015 recommending the use of safer sharps. So these are, looking at technologies that can increase the safety of sharps to try and reduce the risk of injuries. Again, I'm not going to go through this in huge amount of time because of time. And these are some systematic reviews that just showed looking at, are these devices actually helpful? The jury is out on some of them because some of the reviews haven't shown that they're safer than your standard sharps management. But I think, again, a lot of these are quite out of date now. And as these use of these devices improve, hopefully we get more data to see whether or not they are useful. And then in terms of protecting or looking at healthcare workers, so all healthcare workers, Sorry, I didn't intend to speak for so long, but anyway. This is just health clearance for healthcare workers, which again is part of the responsibility of employers to ensure that all healthcare workers who are new to the NHS or returning have the appropriate offers of immunization and screening for bloodborne viruses. So I'll just skip through that. I've only got 3 slides left, so we're nearly done. So again, this is, I won't go through this. This is just a risk assessment for management to exposures of body or bloody fluids. This is what should happen. Whether it's a healthcare worker or a patient, you need to do a risk assessment and manage according to that and follow up. And these are just the things that need to be considered: the type of exposure, where it happened, the source patient. Do you know whether or not they're infected with a bloodborne virus? Can you test them? The healthcare worker or have they been vaccinated against Hep B? What's their status? What kind of sharp it was? Was it blood stained? And if you don't know, is it an area where you might expect a high degree of bloodborne viruses? And then this is just the testing that you need to do.